Hello and welcome to another episode of the Melbourne Athletic Development Podcast, Lateral Think. Today we're very lucky to be joined by Pam Boekel. Pam is an orthopaedic surgeon. Tell us a little bit about yourself, Pam, and where you're going and where you are at the moment.
I finished my orthopaedic surgery training in February, so I still have to
pretty cool.
Fight down the imposter syndrome of saying I'm an orthopaedic surgeon. Better not say it without a stutter.
After how many years of training?
So I finished medical school in 2009, so I started 2010, so 12, 13 years.
And is that always the case, that it takes that long, or has that been a bit of a different journey for you? You chose to kind of go a different path before going into orthopaedic training?
No, I was always wanting to do orthopaedics, but it did take a little bit longer just to try and get on the training program, which is, so basically you do your junior doctor years, then you do orthopaedic sort of junior registrar years, and then you've got to get onto the training program, which is 5 years, and now it's sort of shortened to 4.5, but it's competitive to get on. And
I can imagine.
And I didn't know how to play the game for a really long time, so it took me a little bit longer than most, but that's okay.
What do you mean by playing the game?
I had no idea about things like unconscious bias, and I couldn't understand why I could say something to the same group of people in the same way as my male colleagues did, and they would be, buddy, and I would get slapped with bullying complaints. And it's because it coming from a female voice, it does come across as harsher. Yeah. And it took me a really long time to realise that, and that's okay.
Did you have to go through a bit of like a sort of self-awareness process to say, okay, what I'm saying is not inappropriate, but I have to understand the context I'm in, good, bad, or indifferent, because obviously, as you sort of said, it's layered with structures that are sometimes historical, but it's important for me to actually recognize this and behave in a way that's going to optimize whatever I'm trying to do.
Absolutely. And for a long time it took me, I was so angry that I would have to change myself because this is wrong, and I guess, school didn't prepare me for this. I went to an all-girls school and they're like, feminism's happened. You can do whatever you want to do if you work hard enough. And that's like the biggest lie. And so I was like, but why am I... But
question on that, I don't think being an orthopedic surgeon still is as popular for females.
Yeah.
Is that still the case?
Yeah, so I'm one of 9%.
One of 9%.
9% female orthopedic surgeons.
Are there a lot more younger ones that are coming through? Or?
Yeah, so...
or is it just not something that females tend to choose in and is there good and bad reasons for that?
Yeah, so certainly there's historically, obviously, not very many women in orthopedics, and I think, that was a downside for me being training because I didn't have any female mentors, so I sort of judged my behaviour off my male colleagues, which was, as we've explained, not very good.
It's dangerous,
yeah, exactly. But there is, the sort of funnel phenomenon where, more girls at medical school want to do orthopaedics, and then gradually as the years go on and people get more senior, we all drop off.
Why is that?
So a big part of it is selection into the training program. And again, this comes down to unconscious bias, that a lot of the selection criteria comes down to your references and also an interview. And so if you're being interviewed by predominantly white private school educated males, it's human nature that if you see yourself in someone, that you're going to mark them more favourably.
Yeah.
And so the Australian Orthopaedic Association, the AOA, is trying to introduce unconscious bias training to the people who are doing the interviews now. They've made a mandate that, so the interview is a structured interview. There's about 5 stations with 3 interviewers, and there always has to be 1 female panellist on each station, which, again, helps to decrease that bias. But it's pretty funny to talk about unconscious bias training with some of the older orthopaedic surgeons because their very clever brains couldn't possibly mislead them.
It's interesting.
It's an expert problem, isn't it?
My brother is a classical pianist, and he's worked in opera companies with orchestras. And interestingly, they had a similar issue where historically people playing in the orchestra have been males. And the way that they've actually got around it, and I think most big orchestras do this now, is when you do your audition, you're doing it behind a curtain so that the people listening cannot see you. And often you're doing it, they have carpet laid down too. So if you're wearing, for instance, heels, they can't hear that either. So they don't know whether it's who actually is performing. And the reason is to take away that unconscious bias.
Yeah, absolutely.
But there's actually still been some issues. I remember Tom, my brother, telling me a story about a female getting into the position in the orchestra got the position, but then when they realised that she was a female, after her probation period, they said, we're not extending it. But the rest of the orchestra ended up saying, look, she has to say. She's clearly the most brilliant musician that
for this position,
yeah. But yeah, so it's one of those things where I don't know if you can do that in
medicine. Exactly. No, it's a bit hard, but I mean, I think at least they're trying. And so this year, for selection in Victoria, 4 out of 11 trainees are female, and so they're seeing that as a big win, but it's still not 50%, but I think we're getting there, which is...
Do you think that there are behavioural, personality, or even just general interest features that attract males more? Is that, or do you think it's more
there seems
of
to be stereotypes associated with different...
I
mean, and that's an issue in itself, but there seems to be stereotypes associated with different specialisations.
Yeah, absolutely. Orthopaedic surgeons are sort of renowned for being the jocks,
the cowboys.
Yeah, exactly. And there's a saying, level 6 evidence, orthopaedic proverb. Everyone in healthcare wants to be a doctor, and every doctor wants to be an orthopaedic surgeon. And so I think that just goes on to the fact that you have to have a bit of ego to be a surgeon.
Yeah.
Well, you have to have the audacity to think, I'm going to cut into you with a knife and a saw and I'm going to make you better.
Because you've got to convince people that that's the best option.
Well, and also convince yourself that, yes, this is the right thing to do to someone. I don't know if you've ever had you guys have been to see some surgeries, but it's not delicate.
No,
and that is also why... a lot of women sort of end up not doing orthopaedics because of the physicality of it.
Yeah, sure.
Certainly worldwide, there's a lot, female surgeons particularly do hands, foot and ankle and paediatrics, and I think there's a reason behind that because it is really physical. I'm doing shoulder and elbow surgery, and I had to assist when I was in my last job. I had to assist in a hip replacement. Hadn't done one for about 4 months, and oh my gosh, my back just hurt, hefting 100 kilo legs around, and it's just I'm so glad I'm not going to be doing this for the rest of my life. But I think that's not just an issue for females though, smaller statured men, and even just as you age, I think we have to get better at making things more
do you think that will change with technology?
Yeah, absolutely. So
what do you, because I know that there's a lot of changes starting to happen with different use of robotics, the setup of the actual theatre. What kind of things do you think are cool that are kind of starting to influence the surgical realm in orthopaedics? Yeah,
so robotic surgery is a real game changer. Yeah. So it's not that you sit at a computer and sort of play a computer game and the robot does the operation for you. Basically what the robot does is it registers parts of the anatomy in time and place, and also matches that to a CT scan or an MRI scan that's done prior to surgery. So then you can use the calibrated machine to say, yes, I'm putting this implant in where I want it to be. And so for a hip replacement, for instance, it's just
really improving the accuracy.
It's magic, so usually what you have to do to put the cup or the acetabular component in for the hip is that you have to lean right over, arms extended, smash it in with a giant mallet that's bigger than my head. I can barely hold it. And I'm standing on a step on my tippy toes. And whereas what the robot does is it holds the acetabulum in place. Yep. And then you just have to get your mallet and hit it. And it says, you've got on the correct depth. Done. And so it's a lot easier.
And are you seeing a lot better outcomes with that? Like post-surgical pain, the return to function is increased, or are we too early to say?
I think it's too early to tell. Certainly the first year reported in the Australian National Joint Replacement Registry for robotic knee replacements was that there was a higher than expected infection rate.
And why do they have any idea why?
Yes, so the majority were done at a certain hospital in Melbourne that doesn't have very good laminar flow. There's more personnel in theatre, so when you have more people in theatre, that's more personnel shedding squamous cells and bacterial cells off their skin, and which can then contaminate the operative field. And because with the machine, you do need a few extra operators. So, and plus there's lots of people wanting to see this new cool technology. Yeah, sure. That's evened out now, but the first year was pretty unimpressive. But look, I think time will tell. So when the similar thing that we had before robotics was navigation, which is similar, but doesn't have obviously the robot holding the pieces in place for you. And what that showed is that it decreased the outliers, so the ones that were really way out of line, you're putting them in 10 plus degrees incorrectly, which does decrease long term your loosening lysis revision rate. But
have you heard about some of the development in robotic technology where surgeons can then perform surgery on someone remotely? I know there's very early stages of that technology.
I haven't heard of that happening yet. Okay. No, I think probably that'd be pretty cool.
Look, I feel like that's still in the development stage as opposed to the actual application.
Yeah, exactly. Exactly. But I could imagine that being utilised with people having about 4 theatres going and then just like turning around from one room, smashing in components. But I mean, that just goes to show like there's more to surgery than just putting the implants in for a joint replacement. But yeah, so somebody still has to do the dissection down from the skin through muscles to bone. And, you still have to feel like it's very tactile. You still have to feel the balance of the joint replacement as well. Make sure that it's
brings
stable.
on something like recently we did a podcast on skill acquisition, and like to me, I think the biggest component that's different for someone who goes down the surgical realm compared to someone who's a physician is the skills you need to develop. For you, was that part of what attracted to you towards it? And also, how did you find that process of having to actually really develop, motor skills as part of your training?
Yeah. So, I mean, like that's the fun part. Operating is the fun part of surgery.
Well, for some people, I'm sure other people don't really like it.
Yeah, maybe that's why I should be doing surgery. So, I mean, certainly, we get the sort of again we talk about stereotypes, and orthopaedic surgeons has the stereotypes of being the boneheads that just like to operate, but it is a big component of our work life is gaining those motor skills, and not everyone has it. I think do you think that's a thing that selects people out over time, is that they actually don't, well, they probably don't admit, but
how are they doing, this is our ignorance, how are they actually even selecting on as you're going through a training program? Are they saying that, well, actually your skills aren't up to standard with your surgical techniques?
Yeah, so surgical training is like an apprenticeship. So it's like, your chippies, your plumbers, you're sitting there with your boss doing operations, and you do bits and pieces with the boss helping you. And and then, as you progress through your training, you do more and more of the operation until the boss is standing behind you, not touching the patient, and you're doing it independently. And so some people do get weeded out, but there's a belief in the surgical world that the technical skills, the technical ability of doing the surgery is the easy part to train. The hard part to train is decision making, integrity, and things like that. So
with that in mind, what kind of things are they putting in place to improve the decision making processes?
Yeah, that's a good question. Look, training's a big thing. They've just overhauled the orthopaedic training program to this new program called the AOA 21, very fashionable, and basically now they've changed it to, instead of a time-based program, which is what I did, you did your 5 years and then you passed your exam and then you get off, but now they're making it a competency-based program, so you have to prove that over the course of your 4.5-5 years that you've done a certain number of operations to a certain proficiency, and you have to get regular feedback entries on your little app that the surgeons do, and you have to be have supervised examinations of patients and things like that, and making decision plans. But the reality of that is that it's more just another hassle for the poor trainees to have to do.
Well, so the thought that I have with that straight away is the subjectivity of the assessor.
Yeah.
Because to me, one of the things that's always interesting when you talk to surgeons is, as you said, there is ego involved, but they're always espousing I have this technique that I've been developing, or whatever it is as if they've reinvented the wheel.
Yeah.
And so, and we have this issue sometimes in our training as physios, where you clash with supervisors because they say, oh, I would have done it this way. And you say, well, the outcome was the same.
Yeah.
So why do I need to use this specific technique or approach? Is that something that kind of, as they start creating more competency-based assessments, does that become the challenge for you guys?
Absolutely. And often what we see is that the feedback sort of mechanism is more used as a punitive kind of thing. If you get bosses who don't like the cut of your jib for whatever reason, they'll be more likely to mark you down.
Is that something that still, because I know that it's one of the, I'm happy to admit this, at certain points I thought, maybe I wouldn't mind actually exploring being, going down the medicine path after finishing physio. And the thing that I kept coming to every time I spoke to someone who went through the training is they said, like, there's such a hierarchical system, and I knew with my personality I just wouldn't survive that at all.
Yeah.
Really?
Is that something that you said that, you mentioned before when it came to the unconscious bias, stuff that you had to go through? Was that something that you have to kind of just accept at a certain level, that because of the traditions, because of the way in which it's been structured, you have to accept that there is a hierarchical nature in which there's always this idea that, we went through this, therefore you must follow the same path?
Yeah.
Know your place. So
Well, I find it disappointing in some ways, because to me, like, as anyone who goes or has to train or coach or teach people anything, that concept seems to me to be not only not useful, but it doesn't necessarily create confidence for that person to be able to explore their competency. I don't know if you have any thoughts or competence.
I think the thing you're highlighting here, though, too, is the ability to be somewhat innovative and creative, and it's something that it's more clear when you look at, say, surgeons versus medical specialists, because in medical specialisation, it seems to be very much this is best practice and this is what you follow, and very much that's usually like pharmaceutical driven. Yeah. There seems to be a lot more variability in the surgical approach, because you're going to have variability about whether one surgeon thinks you should get surgery or whether you shouldn't.
Yeah.
And then obviously the other thing is how you actually go about doing the surgery itself.
Yeah, exactly.
Where do you think that culture comes from, of experimentation and exploration? They're always doing studies, they're always looking at new techniques.
Yeah.
Versus in the more, on the physician side of things, they tend to be very conservative, and they'll wait for other people to do the research before they'll try new practice.
Yeah, I think to a certain extent that also exists in orthopaedics. Like level 6 evidence orthopaedic proverb. You never want to be the first person to try a new technology, just like you don't want to be the last person to leave an old one.
Well, let's say from a legality standpoint too,
exactly.
Make sure you're not stepping too far out of your
doing
your
parameters of what's acceptable.
But there just does seem to be, this culture of, exploring and being willing to try new things. Is that something that they encourage, or is that again that personality of being the sort of cowboys of medicine?
Yeah, I think definitely.
Cowgirls.
Yeah, cowgirls. Yeah, exactly. And I think definitely competition is a big part of it. I think over several reasons. So it's easy in the physician world to have evidence. So because it's really easy to do a double-blinded randomised control trial on a drug, because you have one sugar pill and one drugged pill, and then you look at the outcomes. It's so hard to standardise sham surgery in orthopaedics, and hard to get that through an ethics committee, even though it's been done before. It's ethically, giving someone an anaesthetic and then not operating on them is pretty shady.
Would you get that? Would you get approval these days to do that kind of
probably
research?
Not. Yeah, I mean, I think probably 2000s was the last paper I read that was involved sham surgery. But and so therefore you don't have as good evidence to support and what you're doing. And also likewise, you can find a case control study or a cohort study that will support whatever you want to do, because that's the beauty of orthopaedics, is that by and large we've got operations that are easily reproducible with largely positive outcomes. But if you think about it, again, we've got really educated people, surgeons, from the 10, 15 years it takes us to train. We change jobs every couple of months, sometimes change hospitals, change states, change countries every few months, and then once you get to the end of it, all you're doing is the same 5 to 10 operations day in, day out. And so what's the next pinnacle to climb? And so you want to get the best outcomes possible, because you want to be the best and you want the best for your patients. And so that's where this kind of tinkering comes into it, wanting to get the best and trying new things.
It reminds me, I don't know if you've seen any of the work of Nassim Taleb, but he talks a lot about this idea of the tinkerer and how sort of knowledge gain tends to happen more in that iterative process. And it reminded me of what you said about how being a surgeon by and large is much more of an apprenticeship than it is sort of like a learning through theoretical kind of understanding. Do you see that as being helpful for developing the explorative and tinkering kind of nature?
Yeah, definitely. I mean, I suppose human beings, we're pretty gooey beings. There's lots of, no one's the same, everyone's different, and everyone's body responds differently to surgery or to interventions. It's not like we're, you don't take, you take your car to the mechanic, they're going to change the tyres, they change the tyres, you're good to go. I mean, everyone responds differently to surgery. As you guys know, you'd see the rehab, right? And so, I think, and also once you finish, again, it goes back to that hierarchy. nobody's really going to question you. Like when you're training, you're constantly being questioned, why did you do this?
That
why
might be
did
a
you do it that
problem
way?
in itself.
Yeah, exactly. And so it can lead to great outcomes. And if you tinker in the right way, as in you have a research protocol, you sit down, you consciously think, okay, this is what I'm going to do for this amount of patients. You open disclose that to the patients, and you go through an ethics committee and do your follow-up adequately. Then that's where you can get good outcomes, but also, it can result in terrible things happening. And that's why we do have checks and balances like the Joint Replacement Registry, checking up on outcomes of people. That's why we have weekly x-ray meetings and things.
Yeah, it's interesting you say that, because we had a conversation with a couple of barristers. They worked in different areas, but one of the things that we found really interesting about their decision-making process was that they tended to have a lot of checks and balances in what they do, and they would often actually almost argue the opposite side of their case, because obviously they need to prepare for whatever they're going to be exposed to. And I think that's something that we miss a little bit in healthcare. Once you're finished, like as you're going through your training, people will ask us, "Oh, did you think about this?" And like, if you did it this way, what would happen? You go, "Oh, I didn't think of that."
Yeah.
Is there enough of that going on, you think, in healthcare, that we learn to be able to argue both sides of the coin? Because I think it does happen sometimes. You said you have case review, and if you're in a good setting where they're doing that regularly, it happens.
Yeah.
But I think there are a lot of places where, especially, I think as people get more experience, they want less and less of that feedback. They want less and less of that constructive criticism.
Yeah, exactly, because I'm the most experienced at this, therefore my outcomes are fantastic. And you often get the senior surgeons like, "Oh, I've never had a dislocation," and then in the back of my head I'm like, literally last night I popped in one of your patients dislocated hips. Like, hang on, what? And so I think and I think that's a generational thing. Like I've had a conversation, like lots of those sorts of conversations with, we call them the granddad surgeons, and then like the generation lower, who are sort of been out 10 years or so, I think they're a bit more aware of it. Because I did catch one surgeon once who I'd just popped in a dislocated hip. He's like, "I've never had a dislocation, except this one." And I'm like, "Yes, well done, sir."
Would they said that if you weren't around?
Yeah, I don't know. What? Yeah, I don't know. Yeah, right. Yeah, I don't know. But it's pretty funny, and I think it's a generational thing, to be honest.
Do you think that will continue to change, and some of those sort of feedback mechanisms will get sturdier?
Yeah, I think we're selecting more. I think with increasing diversity in selection, I think that brings across different ideas. And so in the private sector, there's not many x-ray meetings. So usually in public sectors, we have once a week, we have an x-ray meeting where we go through all the pre-ops and post-op x-rays with the team, and you can ask questions and grill the registrars and all that sort of stuff. Private hospitals generally don't have those, but they're now getting them in some of the bigger private hospitals. It's really interesting though, because I've had a colleague who was at the time a junior surgeon attending these meetings, and he's looking at some of the x-rays and they're awful. And people are just saying, "Oh yeah, good job, mate," like to these senior surgeons. And he's thinking in the back of his head, "Hang on, that's not correct. Like that's not in the current evidence." But he didn't feel like he could speak up.
Yeah.
Well, I was just actually going to say that, like, even from this conversation so far, it seems like you're quite willing to be very open and critical about your own experiences and profession.
Yeah.
Is that something that you feel more confident now doing, that you've finished, or has that always been a part of your personality?
This is maybe why she took a longer to
That's exactly right, John. This is exactly what I mean by I'm hopeless at playing the game. I have no poker face. And I think being honest is really important. And so I mean, it's certainly got me into trouble. And there's been certain jobs that are awful that I was in, and I had to get Botox to stop my poker face. It's hard. And I think as you get more senior, you can get a bit more. You have more gravitas to say, "Hang on, let's have a think about this." But difficult conversations to have.
Is there much discussion happening about how to have that sort of professional humility? And I say that, as I said, for us, and I think you seem to follow the same pattern. I don't know, like all the conversations we've had over a long period of time, for you, it's always about trying to get the best outcome for the patient. So are there sort of in your training, the way it's going and the feedback that you get, are they trying to educate you, like, it's important that you actually understand you have limitations in your own professional practice, that you should be working to improve over time, but you're never going to necessarily nail everything all the time? Because to me, there is a weird balance that goes with the confidence associated with, as you said, cutting into someone and having enough professional humility to say, actually, I got that wrong, or I could have done that better, or I'm going to go and seek out feedback to improve this. Particularly when I think that there is an interesting expectation placed on surgeons in particular to have the answers for people.
Yeah, absolutely. And a colleague of mine has just been doing some research on this, and it's called the superhero surgeon. And, you know, what are perceptions of people, you know, surgeons when they're admitting indecision or you know, not knowing what to do next.
To us, like we speak about this often, if you're willing to admit where your information or understanding or even your willingness to accept the complexity of, say, whatever situation you're dealing with, that actually shows strength, not sort of professional weakness, but it's observed to be the opposite in the way people perceive it.
Well, and in fact, I think that's something that works to some people's advantage who, like you said, particularly in our profession where you have, say, specialist physios who all they see is hip issues or shoulder issues, which in itself can be debated about whether that's the best way to go about it or not. But the one thing that you see within their personality trait is they're so confident with what they say to the patient of this is what it is and this is what we're going to do. And there's something quite valuable in doing that as opposed to being like, well, look, we could do it and, you know, these are the advantages of doing it, but then there's also these disadvantages and you could do this. And that level of uncertainty, even though it's actually perhaps more accurate, I think leads to less buy-in from the patient.
Yeah, you're absolutely right. Yeah, showing uncertainty to the patient, I think, it damages the, you know, doctor-patient relationship or clinician-patient relationship.
But I think you see that as dangerous though, because it's probably selling them something that's not it's not accurate.
Well, particularly, I think in surgery, because the reality is, it seems that a lot of people in the general population have this embedded belief that if all else fails, I know I can get surgery and that's going to lead to like fixing me, so to speak.
Yeah, and it's often not the case at all.
I often wonder that too, of like, I'm interested to hear what you say about before when you're assessing someone to see whether they are appropriate for surgery or not. How much detail do you actually go into like what actually happens during the surgery and understanding like the remodeling and rehabilitation phase? Because I wonder, would that change people's perceptions if they understood this, like the actual seriousness of what surgery actually means?
Yeah, it's really hard because people come in with their own biases. So, you know, the GP's told them, oh, you've got bone-on-bone arthritis, you need a knee replacement. And the reality is that 1 in 5 people hate their knee replacements. And we don't know who they're going to be. You know, we can guess, you know, younger females with, you know, mild arthritis on their x-rays, poor resilience. And those people are going to be, I mean, you know, depression, anxiety, that describes quite a lot of the population that come in wanting to have a knee replacement. And, you know, their GPs told them that they need a knee replacement, but not taught them how to take Panadol properly. And they've not had physio, they've not had anything. So it's, I think the difficulty is trying to then create a relationship so that patient trusts you. It all comes down to trust. So you've got to be able to create that relationship first. Educate them to a level that they want to be educated at, because there's some people who don't even want to hear about the surgery. You start to explain it to them, they're like, you know, put their fingers in their ears and start shouting for you not to say it.
Sure.
And those people are really worrying me because they're like, yeah, I'll just sign, it's fine. I'm like, no, I need to tell you about the complications and the risks. And they're like, no, I don't want to hear it. And you're like, oh God, you know.
I'm actually legally obliged to make sure you inform consent. So.
Exactly. And look, sometimes those people are the ones that you probably want to send away. Give them a few exercises to do, send them to your trusty physios for an exercise program to have a bit more and a bit more time, and have another professional tell them, no, you can get through this with just some exercises and some Panadol.
Well, I think one of the, like, it's a bias that kind of goes the other direction in our profession. I think there's often too many physios who are always advocating, you know, non-surgical management, and it pisses me off as well, because sometimes it's the most appropriate plan of action and they wait too long for people to actually go down the path of whether it's a joint replacement or some sort of repair or whatever it is, and you're actually wasting that person's time saying to them do 6 months of, you know, non-operative management, because the outcome's going to be better if they go down that path. And sometimes I think it's almost because they're trying to advocate for what their profession does.
Yeah. When all you have is a hammer, everything looks like a nail.
Yeah, definitely.
Yeah.
going back to what you were mentioning before, in relation to your friend, like I'm interested to hear about that study you're saying about the
superhero surgeon study. That's sort of looking at confidence and competence and perceptions. And so this is amongst trainees' perceptions of surgeons who admit when they're uncertain. And and this study was born out of, so she's a paediatric surgeon married to an orthopaedic surgeon who's a wonderful orthopaedic surgeon, and she was saying that
well, they're not going to admit otherwise.
He's terrible.
No, he's
the worst.
That's why I did the study.
Yeah, he's wonderful, because he showed me that it's okay to be vulnerable in surgery and okay to be like, oh, I'm not certain, Pam, what do you think? And he would often do that to me as a senior trainee,
like during the actual surgery.
Yeah, he's like, what do you think, Pam? And so, so I found that really valuable, and I found it really interesting that his wife's now doing this study. And she said that she started this study because she had a bad outcome, operating on a baby, awful. And so she questioned herself, like, do I even have the capacity to be a surgeon? And
to me, I think that is one of the great strengths of females in general. It's obviously a generality, but I think females are much better at admitting when they're not sure, or they make mistakes. Guys are hopeless at it.
Yeah.
Because we can often be overconfident when our competence doesn't match that.
Yeah.
And always looking for that confirmation bias.
Yes.
And
I think that is probably hopefully it's probably one of the things that helps orthopedics improve is, as you said, that diversity of ideas and even personality traits and approach. But I think it's interesting that you mentioned that she went through that process, because it doesn't surprise me that to me that seems to be a more common trait along what females tend to exhibit. Yeah,
well, I mean, that's society, isn't it? I mean, we raise girls to be perfect and boys to be brave, and so and that sort of brings out this confidence-competence mismatch. Lynette Hollian, she's the president of the AOA, first female president. I think she was the second woman to be trained in orthopaedics in Australia. And she said just on the weekend last weekend at a conference, that she often saw trainees who were confident, often their competence was inversely proportional. And as female trainees, we ubiquitously get complaints that we're not confident enough.
Yeah.
But really it's just this self-reflection, not necessarily self-doubt, but it's just questioning. And, are we doing the right things? Which I think we're probably more vocal about because that's the way we're raised. And certainly that's what Amiria's study showed, that the trainees, male and female, greatly, really respected surgeons that said, hang on, let me just pause for a minute, I just want to think through this, as opposed to the surgeons who would bluster through it and quite clearly be struggling with something but not admit, I need help.
Even with the term, the superhero surgeon, how do you, as someone who's now finished and is going to be sort of having people consistently coming to you asking to say, can you fix what my problem is? How do you, have you sort of come to terms with how you're going to approach that, and how you carry that responsibility that people will come to you having this expectation that you can fix whatever ailment they have because you're the surgeon? Yeah,
exactly. And surgery will fix me, like you said. Look, I think it's something that I've been very aware of all through my training, and I think
are there strategies that you kind of have developed that help you to be able to remain objective about your decision-making processes and what you communicate?
Yeah, definitely. And I think the key is to remind them that we can harm people with surgery.
Yeah.
You can die from an infection, but you're not going to die of your knee arthritis.
That's a really good point, because I always think about this, people don't think about the iatrogenic effects of any intervention that you do.
Yeah, exactly.
We get very frustrated typically with terrible physios who will do things and they don't understand that actually they're imparting a negative outcome without realizing it. And often one of the really interesting parts, I think, is in communication. The iatrogenic effects of communication
and language
can be horrendous. As I said, when you tell someone you have bone on bone, that gets burnt into their brain for some weird reason, and they go, oh, well, I can't do this because I've got bone on bone.
Well, and the funny thing too is I think in our profession that we're doing a pretty good job of communicating that language, but then we've actually replaced it with other language where at the moment it's all about this motor control of, you're not turning your glutes on or whatever it may be.
Which is just horseshit.
And not to mention
it's inaccurate.
It is inaccurate, but it's reinforcing that same issue of going what are you talking about? And two, do you understand what information you're giving this person? Because all of a sudden they think that their body is just not working for some reason.
And you know, you will know this, Pam. You know, and I know that you've had back pain in the past. When someone says like, "Oh, don't bend over, don't pick anything up," and then 3 years later they're still doing that. They're like, "Oh, I don't bend." You're 27 years old. What do you mean you don't bend?
Yeah.
How do you tie your shoelaces? You know, like
are you a human being or are you a piece of wood? What are you talking about?
Yeah, exactly. And I think, you know, we're all time pressured, right? You know, particularly like GPs, you know, they've got 5 minutes to see a patient, basically. You know, our clinics are always overrun, particularly in the public sector, mostly because I'm spending my time talking to patients about how to take Panadol properly. And that it will work if they take it properly. Anyway, and so I think taking the time to have a discussion with these patients who are often really confused, you know, writing things down. There's, you know, certain websites you can direct them to that have information. But it is difficult. Yeah.
Well, it's difficult too because for a lot of orthopaedic issues, I mean, there's obviously ones associated with, say, trauma, but a lot of them are more these type of chronic
conditions,
degenerative conditions that are typically multifactorial. And that's an issue in itself because you need to actually spend a lot of time talking to that person saying, there are so many things here that you can actually address that will help this.
We'll replace your joint, but you know, you need to look at weight management. You need to look at, you know, your healing process will be improved if you stop drinking and smoking as much as you are, and all of these different
all the psychological, physical, metabolic stresses going on. But that can be difficult because obviously people are typically not open to a lot of change. But the issue too is most of the time people expect to see a health professional and they're going to get a nice clear-cut answer. Like, interestingly, last weekend I went bushwalking and I got a leech bite. And I've had leech bites before, no issue. And then a couple of days later, my arm starts getting really, really red and swollen. And I've gone, oh shit, this isn't good. And I actually went to a after-hours clinic because I thought I need to get this looked at straight away. And again, fortunately, you know, you only got a 5-minute appointment, but the GP looked at me and goes, yeah, you got cellulitis. You need to take antibiotics. I go, great, like nice, easy solution. And, you know, guess what? Took the antibiotics. It's gone.
Perfect.
Thankfully. But,
Yeah.
you know, the reality is...
I'm having my arm empty.
Exactly.
Do you want to do it?
You're fast.
But I don't want to spend money on the anaesthetic, so can we just do it while I'm
with the saw.
Exactly.
But then it's obviously a much different situation where it's, okay, I've got long-term hip pain. Maybe have some osteoarthritic conditions, but osteoarthritis, as we know, is just a musculoskeletal condition. It's related to so many systemic factors.
And could it be coming from their back? Could it be coming from their knee?
Well,
like there's all sorts of things. And so, I mean, you go through a process, and I think, and you know, my fellowship in Townsville really highlighted this. You don't book patients for surgery for conditions like that off one appointment. You've always got to send them away. You know, ensure that they're exhausted non-operative treatment, because 9 times out of 10 they come to you and they haven't had physio, they haven't had an injection. And so, you know, particularly with the shoulder, you send them for a corticosteroid injection, get them to take a pain diary. And that's also really important, because if the corticosteroid injection doesn't work at all, because usually they'll get some relief, even temporary, just from the local, then you know that it's not the shoulder, and you're not going to fix them with surgery. And so, I mean, a spine surgeon I know, he's like, oh, it's great news, surgery won't fix you. So you don't need surgery. And he phrases it like that to try and get the patients on side of like, yeah, I don't need surgery, even though they come in desperately wanting it. I'm not as good at that kind of wordplay.
Well, I was going to say, what do you find are the outcomes with patients who go, look, I want you to do conservative management for 6 months, or you don't need management? Like, do you find that they're typically good at following that advice, and do you see change, or do you see them coming back at another point in time saying, oh, look, it's still there? Or probably a mixed bag.
It's a mixed bag. It really depends on the patient, and you can often tell the ones, like, they start to glaze over when you talk about taking Panadol and going to see a physio. And you know that they're going to come back to you in 3 months' time, having done nothing and still wanting surgery. And then there are some that are like, you know, particularly up in Townsville, there's a whole lot of cane farmers. If you told them that they didn't need to take time off work to go have surgery, they were like so excited. So they would be really good at their non-operative treatment because it wasn't in their best interest to have surgery. So it really depends on the patient. And you know, and I think this is probably going to be something that emerges as my private practice, you know, develops. That I know a lot of private surgeons have those patients who come in, don't do their preoperative, you know, prehab. And he's like, all right, well, I'll just do a knee replacement on you anyway. And he reckons that they have good results. Like, it's a friend of mine, and I'm thinking, I don't know if I'd be able to do that.
Well, I was actually going to ask that. Do you feel pressure to a certain extent? Because a lot of the time people are seeing you as a last resort.
Yeah. Look, I mean, I'm sort of pretty, you can pick who's going to have good results and who isn't. Yeah. And again, I've been raised to be perfect, so I don't want to operate on someone unless it's going to work, right? Because outcome, we can certainly make them worse.
Yeah.
But there will always be somebody else out there who will operate on them.
Yeah.
And I think, as a patient, that's key, is to go find a surgeon who's busy, because he won't operate on you if you don't need it, or she won't operate on you if you don't need it.
Well, that's something that we do is, if we refer someone to a surgeon, it's a surgeon who will know will do surgery if it's necessary, but also won't do it if it's not necessary.
Yeah. And that tends to be one of the key things that we always look for when we refer to a surgeon, is that we know that there's been people we've sent them to and they've said, you don't need surgery.
Yeah,
because that way at least they said they're not doing it just because
they've got space on their
theater list. They've got space, and they want to be busy.
Yeah.
Which is helpful.
Yeah, and there are people like that. But it's interesting though, from a patient perspective, I've never had anyone come up to me and talk to me about that. But I have had patients in the public sector when we've said, good news, you don't need an operation on your fracture despite what ED's told you. And then the families have come down on me like a ton of bricks saying, no, hang on, you're just not operating on her because it's the public system and you're trying to save money and she's old. And it's like, no, she's just got a non-displaced shoulder fracture that'll heal up fine. Yeah. And she's 80, she'll die if we do a surgery. So I've only ever had the opposite, which is really interesting.
It is difficult, that process, when someone is so, and sometimes it's family, they're so convinced that this type of intervention is the intervention they need. And you're trying to explain to them with as much evidence as you can that this is not the best outcome for them.
Yeah.
Sometimes you can't please everybody.
No, exactly. And I mean, that's the purpose of a second opinion. So, they can go seek their own second opinion, they can go to a GP. And I do know orthopaedic surgeons who were subspecialists, they shared rooms, and they would send the second opinion to their mate in the rooms, and it was like a code of, I don't want to operate on this person, please agree with me.
Yeah. That had the earpiece.
Exactly. So, but that was the only time they'd ever send the patient for a second opinion. So I don't know. That's probably a little bit on the dicey side of ethical behaviour, but still,
In terms of probably changing subjects a little bit, you mentioned that you're doing or specialising in terms of your orthopaedic surgery on elbows and shoulders. What's coming along and you're finding interesting in that space?
Shoulder arthroplasty in particular, they're sort of doing a lot of navigation, patient-specific implantation and stuff like that, which is really exciting. They're doing a thing at the moment called augmented reality. So it's where you're getting virtual reality goggles that puts overlays the CT scan as you're looking at the patient. So again, to try and get the implants in the right position. I think it's probably a gimmick.
Well, someone has to pay for very expensive technology.
Exactly.
May as well be surgeons.
But that's pretty exciting. What else? Look, I mean, shoulder surgery in general is pretty good at the moment. I think a big decision is about, with instability, deciding who should get an arthroscopic stabilisation versus getting a Lateral or a bone block procedure.
With that, in your mind, what are the key things that you're always looking for with deciding that?
Yeah, so it depends on their anatomy, so how much bone loss they've got on the humeral and the glenoid side. And then also the patient factors. So are they elite level athletes? Are they, doing contact sports? And how old are they?
Yeah, typically, isn't it, there's very high association with requirement for Lateral if your first dislocation is below the age of...
It's 20 and under, is the instability severity score.
Yeah.
But, glenoid bone loss is a big discussion. So we had
in what sense?
How much percentage of glenoid bone loss do you need to then replace it with a bit of bone? And there's people arguing, and I was at a conference the other day, and we had everyone putting in the numbers that they look at, and it's 10%, 5%, 30%, and then it's well, how do you actually categorize that?
Yeah, because you can use different measurements.
Yeah, exactly.
Criteria, can't you?
And it's just really, it's Marbo, it's the vibe 9 times out of 10.
Well, I measured it like this.
Yeah, I kind of just eyeballed it. It was actually the biggest proportion of what people did.
I did see one surgeon. I went to a talk with a surgeon who described how they used a technique that went off the 3D CT scan. they actually gave them the number of
Yes.
how much loss it was. And I can't remember the percentages they used, but they were like, I don't eyeball it.
Yeah.
It's based off the radiologist will give me this scan and give me
Yeah.
a number, and if it's over that, then I think it's appropriate.
Yeah, and that's reasonable too, because the radiologists have the time to sit down and
measure those things.
Yeah.
And I think that whatever sort of software they had actually was able to kind of calculate that,
Yeah.
reasonably accurately. So
Yeah.
that to me seemed like a reasonable approach to
Yeah,
it.
exactly.
Rather than just going, I looked at the scan, it's a lot of bone loss.
Yeah, exactly. Yeah, we'll just do it. Yeah.
Do you find that from what I've heard, it is a little bit more of a difficult surgery to kind of develop your skills with, and you've got to be pretty careful around sort of like the neurovascular structures.
For
Lateral.
yeah, because I mean, there's it's tiger territory. Like
Yeah.
you're literally taking off the conjoint tendon, which has the musculocutaneous nerve through it. You tickle the axillary nerve. And you're working down a deep dark hole as well.
Is that a bit scary as a surgeon when you start doing these surgeries and you're going, okay, I actually really have to be careful. I'm not just cutting into someone's glute and going, there's a bit of muscle there, that'll be okay.
Yeah,
that's going to be the hardest thing too, because now you're using keyhole surgery of like when you're looking in there going, I'm pretty sure that's it. I feel like it'd just be nicer than easy to just open the whole shoulder up, but I realise that's obviously barbaric as well.
Well, I mean, it's certainly more straightforward for a ladder to do it open, but you're looking down a deep dark hole of someone really muscular, and it's not like in the textbooks, right? Like the nerves aren't painted yellow. I wish they were. and it's sort of you have your ideas and you know where the ballpark of where the nerve should be, and you just kind of steer clear of it and really hope.
You see a lot of variability.
Yeah. Which is
I think
scary.
that's the thing that people don't seem to always recognise when you do your first or probably undergraduate study. You're like, this is what it's going to look like from an anatomical perspective. But if you actually read the anatomical text, the better ones, they'll say, okay, well, this is the percentage of people where this nerve will run here, and then this percentage of people it'll actually run over the top of that tissue or underneath that tissue or through that tissue.
Yeah.
Well, and the other big one too that I'm interested in is when we think about the muscular system, you see a cadaver, they've cut away all the connective tissue, so it looks like every muscle's separate.
Yeah.
But then I'm sure when you'd see it all the time, you're like, oh wow, there's a little bit of a myofascial expansion of that muscle into that muscle or onto the poneurotic fascia.
Yeah, and you're like, hang on, where am I again? Yeah. Oh, it's so, and you start to second guess yourself and you get a bit worried. And
sure.
But look, I mean, you just got to keep going back to landmarks, and we have a saying, get to bone and stay on bone. You're pretty safe.
It's same as surface anatomy that I use all the time.
So it's
And as like going back to this shoulder stuff or elbow, what's a key problem that you would love to see solved in your sort of throughout your career that tends to give people poor outcomes, or there isn't the solution that even as surgeons you're looking at going, okay, that's still not a great solution. It's better than nothing, but it's not the greatest solution. We want to see something better come along at some point.
Basically everything around the elbow.
The elbow seems to be tricky, doesn't it, in terms of injuries?
Why is that?
It's a really complex joint that has a lot of movement, that's very fine, and there's a lot of force that goes through it. So, and when it gets arthritic, there's no good options. You can do a joint replacement, but they wear out really quickly. You've got a weightlifting restriction. You can only carry up to about 5 kilos for the rest of your life.
Oh, wow.
And they get loose and infected because it's quite superficial. So, not everyone gets them. And because not everyone, they're a really rare operation, it's probably a couple of hundred done in Australia every year. It means that people don't have the expertise in Australia, because in order to get to be classified as a high volume surgeon, so high volume surgeons in joint replacements have the best outcomes, and most shoulder and elbow surgeons would do 1, maybe 2 elbow replacements a year, which is not enough to keep up your proficiency. So a way to combat that would be to have a centralised system. So everyone who is judged to need an elbow replacement should go to one centre.
I'm assuming those people are the ones who've suffered some type of trauma, typically.
So the ones that wind up having elbow replacements typically are rheumatoid arthritic patients with rheumatoid arthritis, because they're generally low demand patients with horribly destructive disease, and those patients, they're often really resilient, and they've got shocking joints, but an elbow replacement isn't great in terms of functionality. But these patients, because they're so resilient, they're so used to having rubbish joints, they don't mind it. Whereas your average, your builder who's got post-traumatic OA from digging ditches his whole life will hate an elbow replacement because he won't get the strength back. He won't be allowed to do the strengthening activities that he wants to do, and won't have the movement back.
is there any development in technology or other types of treatment to improve joint health that are non-surgical?
Stuff,
Yeah, so we're not there yet. I think is
no.
I should.
We're not suggesting that, but it's just we're often sometimes people will ask us, and the limited reading that we've done on it says that we're not there.
No.
But people come along and they're like, I saw this.
I have a patient who emails me all these articles all the time, and like with good intention. He's always like, oh look, I know this is probably not relevant, but what do you think about this stem cell therapy?
But there is a problem, and I won't name names, but there are doctors out there selling it and it's quite expensive treatment for very poor outcomes or even just unsubstantiated evidence for the outcomes.
Yeah, absolutely.
And they're selling this to people and they're spending tens of thousands of dollars doing this kind of therapy.
Yeah, and it's I think it's unethical. And certainly when patients come to say to me and they're like, oh, this person said I should have this injection like PRP or Synvisc or whatever. And I just tell them, look, the evidence isn't there. You're welcome to pay for it, but it's really expensive for, maybe a placebo effect. In fact, a friend of mine, she did a randomised controlled trial in Tasmania during her training, and it was a 3-armed study looking at knee arthritis, and they did a saline injection, they did PRP injection, and then they did a corticosteroid injection, and then followed them up for 2 years to see who had the best outcomes. And the placebo group had the best outcome. Yeah. So basically it's like very expensive for...
You can stick a needle in with some solution in it. As long as it doesn't get infected, it's probably going to
exactly.
feel better.
And they probably like rested for a little bit and that's why they felt better.
Yeah.
And the mind is incredibly powerful in terms of perceiving pain. So in terms of stem cell therapies, so the issue with trying to regrow cartilage is that they can regrow cartilage in the lab, but it's trying to get it then to integrate into the body. So you need to have, like what they're thinking now is that we need to have a scaffold that you can then put those cells onto, that you have to put inside the body to then grow, for the body to grow onto it.
So it would almost be like a combination between, say, like a joint replacement with a scaffold structure on it that then you put the cells onto, and then that'll regrow out once you've actually put the replacement in.
Yeah, exactly. And I mean, we kind of do that a little bit at the moment with osteochondral allograft. So basically you steal a bit of cartilage and bone from somewhere that's redundant in the body and then implant it into places, around the knee.
What's redundant in the body?
Yeah. So medial femoral condyle is a common one.
Okay.
Yeah, often stealing from there.
Steal.
Yeah.
I'm just going to take this.
Yeah.
I'm not going to tell anyone.
Yeah. So you have bits of the body that you can pillage safely.
Do you describe it to the patient like that?
Yep. No, but I think using language like that does help them to realise the severity of what they're about to go through, because they do have like more donor site morbidity. Like it's really bad. Like I've seen patients getting fractures and infections, like knee infections, joint knee infections from that kind of surgery. So it's I think I'm not averse to using relatively graphic language to help them sort of realise the gravitas. So I think, to answer your question in terms of injectables, I think we're a really long way off having an injectable cure for arthritis. Probably not within our lifetime.
And again, it sort of raises an interesting question. Is there such a thing? Like, is there a panacea to reversing degeneration within the joint itself? And then that's a big question mark. You're going to have a better idea than I do, I guess, but...
Yeah, look, I mean, sort of like, science fiction style nanotechnology to reverse the effects of ageing. I don't think so.
Again, I think it comes back to the point I made before too of the confusion of understanding cures for things like infections versus, again, these more chronic type conditions which are typically multifactorial.
It'd be interesting to ask you actually, because I know that this is an area that you've sort of looked at a little bit more, Jack, but utilisation of, say, like food supplementation for the idea of regrowing cartilage. People talking about use of type 2 collagen supplements. And it's in the presence of some sort of loading as well, isn't it, Jack, that actually to try and increase.
There's not a lot of research in it, but it's sort of an theory I had based on some of the research coming out looking at tendon remodeling. Because a lot of people will say that you cannot regenerate or remodel degenerative tendon.
Yep.
There is some research though, Keith Barr over in the States has done of looking at utilising loading and type 1 collagen to help synthesise new tendon. And the reason being that one of the limiting factors for tendon remodeling is having the appropriate building blocks, i.e. the amino acids, particularly the timing of it, so you get the uptake of it into the
because
tendon.
he demonstrated it was like a single case study.
It's a case study, yeah.
Right, so the evidence needs to be expanded, but he did it in I think it was a basketball player. Was
correct? Yeah.
They did over a
Elite
50-day
basketball.
period. They showed like this hypoechoic area within their patellar tendon.
Classic sort of degenerative type tendon change.
Started to the actual size significantly reduced with new collagen structure.
Yeah, but I mean that's just tendon healing all over though, isn't it? I mean, Willett's proof that with his Achilles tendon paper, you know, your tendons need to be loaded in order to have healing.
Yeah, but typically those hypoechoic areas don't necessarily change.
Okay.
What tends to happen is around it remodels. And so the actual function improves, but the actual on imaging it doesn't change a hell of a lot.
Yes.
And this is the first time. As I said, it's an individual study on one case, but
it sort of highlights the question though of, you know, is one of the limiting factors nutritional factor? You know, is that something? And made me think of similar to when you think of for cartilage.
Yeah.
You know, you've got your chondrocyte and you've got your surrounding type 2 collagen scaffold, as you would know, that holds all the glycosaminoglycans. Do we need to actually provide the appropriate nutrients for that extracellular matrix at the appropriate time? Because loading of a joint is similar to a tendon where it's like a sponge, as you would know, pushes all the fluid out, draws fluid in, and associated with that is the nutrients to then provide the appropriate building blocks. I mean, this is all completely
theoretical.
speculation. But I've played around with like talking to patients about it, because there are like type 2 collagen supplements you can take.
Yeah.
But, you know, it's all anecdotal at this point.
Yeah, and I think the timing is different as well. So, I mean, the difference with bone is that it's pretty static. Like, I mean, tendon does regenerate a little bit, but bone, it's pretty much, once the stem cells are gone, the stem cells are gone. And so it'd be tough, I think, to have, you know, parenteral supplementation then target one area. But, you know, hey, look, I'm happy to be wrong. I mean, wouldn't it be great to cure arthritis with just a tablet?
Oh, well, and certainly not assuming that that's the solution. Because it's the other big issue you have is with so many people who have metabolic dysfunction, you're going to have, I know, a lot of dysfunction of the chondrocytes itself. Or the other big issue I know is with the subchondral bone, it becomes more cortical, so you actually can't get the nutrients coming through that trabecular bone into the underlying cartilage.
Yeah, and then some people's arthritis is completely different to another person's. Yeah, some people get super sclerotic, some people grow a whole lot of osteophytes, some people just have heaps of inflammation. And I think eventually we'll realise that all of these different sort of phenotypes would be different genotypes as well. So it may end up being that one person needs one sort of treatment and the other person needs something else.
And I know it might not necessarily be your area, but I'm interested to know, typically we say like fracture healing. We look at it as being something that requires a lot of immobilization. But it's clear that bone loading is, and particularly how bone responds to loading, is varied. Do you think there will ever be a time where we're actually asking people to put more load through fractures?
Yeah, and this all comes into, exactly, personal variation. And so most fractures take, you know, between 4 and 6 weeks or 4 and 8 weeks to heal 90% of the way when it's safe enough to start loading it without causing too much movement, because obviously you can have non-unions if you have too much movement across a fracture. But we can't really tell who's going to heal at 4 and who's going to heal at 8. And so what we're seeing, and, you know, a colleague of mine's done a study on this, CTing people at sort of the 4, 6 and 8 week mark, which is a lot of radiation. But, you know, but then you can tailor, you know,
so you can start putting a little bit more.
You can take your cast off. You can start your active rehabilitation program from now.
Do you think there will be an opportunity for us to accelerate that once we understand a little bit more about those responders and how they respond? Not necessarily just getting people back to stuff, but almost for those slow responders saying like, we almost need a little bit more stimulus for you. How we create that, I don't know exactly just yet, but there's a reason that you're not getting enough, you know, bone lay down. Maybe we can stimulate that somehow with movement of whatever kind or loading.
They have tried that using things like exogen, which is like kind of external pulse, like ultrasound kind of stuff. Dodgy evidence.
I know one of the other things is prescribing parathyroid hormone.
Teriparatide. So actually this is really interesting. Again, just case studies, unfortunately, but certainly at the Austin, at one of my previous jobs, we were using it a lot in patients who were really frail and elderly and had falls around their hip replacements that were all loose, so there was lots of osteolysis around the implant, and then they'd fractured through it. The only alternative is to put in, remove half their pelvis and put in a giant mega prosthesis, which they wouldn't survive. So there's a few case studies using recombinant parathyroid hormone, teriparatide. It's an injection for like 6 months, and and then it does cause bone remineralization of not just the fractured area but also the lysis around the hip replacements. And we had a couple of patients that we used it on, and to really good results, really decreased pain.
Are there side effects to
using it? So
everything else is worse, but the fracture's great.
So, I mean, obviously they have to have an injection every day for like 6 months, which isn't pleasant. It's really expensive, so we had to get special approval from the hospital. And in rat models, it has been shown to cause osteosarcoma, but that's not been borne out in the evidence for humans. And this is often used for like terrible osteoporosis, so it's not just used in
Could you I always go to performance. Could you use it in trying to get someone back from an injury really quickly?
I can answer that for you, and the answer is because I know a subject I teach in the postgraduate course at La Trobe Uni. One of the lecturers who teaches the bone module is Stuart Warden, who's over at Indiana University. He's a professor there.
There's a paper that I found the other day that he did that.
Yeah, and he's actually talked about some case studies of people like following, I can't remember if it was acute or a stress type fracture, and give them parathyroid because they're an elite athlete, like he works in NBA and with NBA athletes, or gets seen as a consultant at least. And they've utilised it, and it seemed to have accelerated their healing process.
Wow, there you go.
But there's something else I was going to ask though too is one of the other big things for bone, again, nutritional. Like when you think about, like I was actually just shared a study recently with our group about looking at omnivore versus pescatarian versus vegetarian diets and the risk of fractures from falls in elderly females, and not to mention looking at all the research around animal versus plant-based protein. And particularly it's very interesting to look at older adults and young children. You see the particular impact of certain nutrients more so, because for a child they're developing, for an older person they've got less adaptability. But the importance of certain nutrients to maintain good bone health in particular.
And that's interesting because now we're getting papers looking at vitamin D and calcium supplementation, which is like the classic kind of duo that you give for people with osteoporosis or at risk of it. And what they're finding is even though you're artificially increasing those levels in the blood, doesn't actually bore out into benefits for the bone.
I've heard this stuff too, and like I know there's actually quite a bit of controversy with things like calcium supplementation causing more calcification of your soft tissue system, like particularly your vascular system. But it's interesting though too, because does that also highlight the issue of trying to induce nutrients in isolation through the form of supplementation as opposed to the whole food matrix? Because there's also quite good research showing that, if you eat a whole egg versus just eating the egg white, you see big differences in your protein synthesis and accretion because of all the other cofactors within the egg yolk, even though it's all fat, but helping with the assimilation of the amino acids into your tissue.
Wow. So, look, it doesn't surprise me. And also with things like diet, I mean, trying to artificially supplement it at age 55 when you've had a lifetime of eating cornflakes with water for breakfast,
Well, and even go further too, because I know there's a big issue with anabolic resistance in elderly people, where if you get them to consume more protein, because that's what's recommended, you actually don't see changes in their muscular or skeletal system, because they need to actually apply some type of mechanical loading to actually improve their anabolic sensitivity. Then they better utilize the nutrients.
It's so complicated, right?
Well, it also highlights that synergistic effect where you're getting the interaction of multiple systems.
So hang on, what do you want me to say? Do you want me to say we should eat meat?
We said that enough already, it's fine.
All right, I think we've just ticked over an hour. So
wow.
Is there anything else that you wanted to ask, Jack?
No, I think that's probably the main things we really covered. I'm happy with all that.
Yeah, sorry, we spent a long time on unconscious bias.
That's great.
Yeah, absolutely.
We appreciate it. Thank you so much for joining us. And
thanks for having me.
I know you're off soon, hopefully over to the UK, but hopefully we get you back at some stage.
Yeah, absolutely. Once I've actually learnt some things, I can come back with some gravitas.
I'm sure you've already learnt some things.
Because you really seem to be lacking in that at the moment, don't you?
No, I'll come back because I want to hit you up for some business, right? Anyway.
Great.
Yeah.
All right.
Thanks for having me.
Thank you.
This episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force platforms, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision-making and objectivity. We are no longer guessing. The greatest thing is its ease of use for both practitioners and clients. There are no wires, no fixed setup. It is a fully integrated Bluetooth system. If this sounds like something that you would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you. Thank you for listening.